So I'm not going to go through the slides and this thing. It's a case-based scenario. We've been learning everything since morning. So the first question is that we are now in an era of artificial intelligence, and we are saying that AI is going to replace everything. Do we all agree? No. So I just want you to be with me for the next 5 minutes to think that sudden maternal collapse is actually sudden. In very, very few situations it will be sudden. Otherwise, we all have missed the red flags, and the red flags being enumerated since morning. So I'll just give you 5-6 examples which are live examples from our practice at Lady Hardinge, and you miss it and you are in a mess, and you catch them and you've saved the patient. And otherwise, you'll suddenly find that the patient is in a maternal collapse. So how do you define a maternal collapse? Maternal collapse is defined as an acute event. Mind you, it's an acute, involving the cardiorespiratory system and or central nervous system, resulting in a reduced or absent consciousness level, which potentially can cause a cardiac arrest and death at any stage in pregnancy and up to 6 weeks after birth. It is rare, but a life-threatening event. Prompt and effective resuscitation is very important, and primarily in this scenario, we are doing a maternal resuscitation. So what it can be a simple loss of consciousness, patients not responding. It can be a temporary drop in blood pressure. It can be faintness, cardiac arrest, and death. And how many of us agree that you will have a sudden maternal collapse in an absolutely normal gravida? Very rare. So what can be the possible situations? Let's see that in a normal gravida who was doing her labor fine, and we suddenly find a maternal collapse with no scar, no high risk, nothing. So the possible events can be, which surprisingly we've started seeing them more frequently, and so many times we are giving this diagnosis, is an amniotic fluid embolism. Maybe yes, an amniotic fluid embolism, patient can have a sudden collapse. The increasing IVF, in these patients also, you will have a background of an IVF or a hypertension or something. A normal gravida to have a sudden maternal collapse, amniotic fluid embolism or another embolism, or a myocardial infarction, which again in a younger gravida would be very, very rare. So a normal gravida, we do not expect that she would have a sudden maternal collapse. The rest, I say that would be giving some red flags. For example, I say that often there are clinical signs prior to the collapse. So these are the signs we've been enumerating since morning. But out of all, I would say that quick SOFA is the most important take. So quick SOFA has 3 components. One is consciousness level. The other is patient is not responding or she's responding slowly. The second is respiratory rate less than 22 and a systolic blood pressure of 90. If any 2 out of these 3 are positive, and if you are able to do an ABG lactate, you will get that the patient is not all right. So I'll give you an example that a patient delivered, normal delivery, day 3, she was in postpartum care. The simple sign was that this patient was not sitting up properly. You asked the patient to sit up and she was lying down. You asked her to show her abdomen, she was not responding fast. So the only positive find in this patient was that she was responding to everything very slowly, though responding. So the consciousness level was not good. So ultimately, the senior obstetrician was by chance on the rounds and said, why the patient is not responding? Why a normal vaginal delivery, day 2, almost about to be discharged, is not responding properly? When they examined, they found a tachycardia of 124, they found a temperature, they found a slight guarding in the upper abdomen. The uterus and everything was all right, which all the residents were looking at. And ultimately, she was diagnosed as an acute pancreatitis. And this was 2 years peri-Diwali, and in spite of doing everything, we lost this patient, in spite of diagnosing everything. The second patient, so as you look at all the features of possible maternal collapse, eclampsia, epilepsy, CVAs. So you have a patient of hypertension, severe preeclampsia, BP going up to 220, 120, suddenly the patient collapses without any signs of any breathlessness or anything. What can be the possible reason? So if suppose, I'm just putting up a situation for the house, There was a blood pressure. Patient had a severe preeclampsia. She had a blood pressure of 180, 120, but she was doing well. We were monitoring her well, and the chest was clear. She was comfortable, and we were doing a termination for her. We put in a Cervigel, and we were planning a termination for her. And you find that suddenly the mother collapses. So what can be the possible thing? Absolutely, the intracranial hemorrhage. So somewhere down the line, we failed to control the blood pressure effectively. So that is one. So you have to think of, if you look at this thing, intracranial hemorrhages in a situation where you don't expect them. So higher blood pressure has to be controlled properly. Now same patient, 180, 120, we've controlled it well. She has fever. She was a chronic hypertensive, and she was complaining of cough for past 4-6 hours. And suddenly you find her collapsed. So what happened to her? Pulmonary edema. So this patient who was simply complaining of cough may not be picked up as a pulmonary edema. So she needed a rigorous auscultation of chest, her vitals, her oxygenation, her ABG, and we would have picked up, decompressed her, given her a diuretic and managed her, and we would have saved her, and we would not have landed up in a sudden maternal collapse. Now, so this is the chart which shows all the problems. And then you can have the rarest of rare possibilities. I still be with the preeclampsia only. So a severe preeclampsia, everything went well, the blood pressure was all right, patient delivered, we were happy, we looked at the postpartum thing and everything good, and suddenly you find that the patient was pale, she has all signs of hemorrhage, there is a tachycardia, output has gone down, you find that the uterus is good, genital tract is good, everything is good, but you find an upper abdomen tenderness. So what has happened to her? Liver, yes. So the house is already learned. I'm just putting the situations. So this happened in our E-room at Harding, and this was one of the rarest of rare possibilities. She had a spontaneous liver rupture. And on ultrasound done there, we found that the liver has gone away and she had a hemoperitoneum. So she was taken up for surgery. The surgeons were called in, and ultimately we lost her in the ICU because of respiratory problems. So the reversible causes should be looked in, and one case I would like to enumerate: patient delivered, and after delivery everything fine, again signs of hemorrhage present, pulse, blood pressure showing signs, tachycardia, hypotension, output going down, all red flags, and patient collapses. There is no evidence of any bleeding per vaginum outside. So what happened? Broad ligament hematoma. So if a need for laparotomy, a need for assessment of hematoma, a pelvic examination to find out that there was a mass which needed a sudden decompression, so an immediately laparotomy would have helped this patient. So the patient's red flags, the signs are very important. That's my message. Always, always before a collapse, there is a red flag. There are signs. Patient is telling you that there is a problem. Sudden collapses are going to be very, very rare. Management of collapses you've been learning since morning from all the experts. I don't think so we need to go into. But yes, the things that we've learned over the time is that if the patient has a pulmonary edema, the pregnancy is more than 20 weeks of gestation. In spite of doing all the efforts and resuscitating her, we are not able to resuscitate. We need to decompress her. And if she has collapsed and it's a cardiac arrest and we are ventilating her, then probably, and we're not able to get the cardiac rhythm, then you should think of a perimortem cesarean section. So maternal collapse algorithm has already been done. Primary obstetric survey, I have told you with the types of cases that are happening. Acute abdomen, sepsis, hemorrhage, hematomas, broad ligament hematomas, they should not be missed. And that eye of the obstetrician who tells that the patient is not good, whatever the evidence may be saying, you can look at the patient and say that this patient is not good, something's wrong with her, and that needs to be examined. So secondary obstetric survey, say before you do the obstetric surveys, you should be ready with your files, the history of the patient, the high risk factors in an era of chronic hypertension, diabetes, IVFs, and later ages of marriage. We need to be very, very careful about what patient is going into and possibility of a collapse or a high risk situations. So perimortem cesarean section, post resuscitation, very important to monitor this patient. Don't relax after a delivery of a severe preeclampsia. She's most high risk in that time. And the last, I would say, documentation. each and every point should be documented clearly by the whole team, by the operating team, the anesthesia, the sisters, and the whosoever is involved in the management, and counseling should be done. Thank you.